You already have a Minute Clinic. Why don't we go ahead and leverage that population health data? Let's go ahead and target those patients who have diabetes, hypertension. Let's get them to goal, but then also be a conduit so that if they are not seeing their PCP, they can still see Minute Clinic for chronic care management or create that connection back to their PCP and then educate the PCP what they have done.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. We're glad to have Dr. Pardeep Shori in our studio today. He's the Senior Medical Director at Navi Health, where he oversees services for Medicare Advantage, Bundled Payment Care Improvement, and ACO members. He's also a regional consultant with CVS Minute Clinic. Welcome to the podcast, Pardeep.
Great. Thank you for having me on.
We're glad to have you here, and we always have a variety of things to discuss on the Business of Healthcare podcast, especially in an election year. There's a lot of noise. So today, we want to focus on some of the fundamental points of interest across the different generations. I mentioned that you work with Medicare Advantage, Bundled Payment Care Improvement, and ACO, and you're also tuned into the strategy and ideas of CVS. So let's start with Medicare Advantage. I've heard some pretty remarkable stories associated with that marketplace. Just where do you see it going?
Medicare Advantage has been growing exponentially, and it's pretty much testament to what's going on with a lot of our providers who are now taking on more patients. I believe there's been an exponential increase in the last couple of years, especially in the Humana United Healthcare here in Texas.
This is a pretty fertile ground for that type of stuff in Texas, right?
Definitely.
Yeah. Well, I heard that like 10,000 people a day are turning 65, and that'll continue on to the year 2031. That's a huge, huge volume growth that's taking place, And most of those people are in Medicare Part A and Part B, which is like the standard issue. And about a third today are in what we call Medicare Advantage. And is the growth trending that some point in the future, 2/3 of the people will be in Medicare Advantage?
Yeah, and that's what, as you were alluding to, the silver tsunami. And we're seeing a lot more people coming into Medicare Advantage or Part C. And a lot of that is because there's more benefits, social determinants of health like transportation, food, vouchers. And then also, as I was mentioning before, a lot of the providers are getting more engaged because they see both an extrinsic, intrinsic motivation. They're able to track and see how their patients are doing in diabetes, chronic care management, and then also they're getting incentivized to get to see their patients as frequently as possible.
Well, I think this market is getting crowded. I like to reference Optum. Optum, I think today now has over 35,000 physicians employed. That's a huge number. So, and they're part of United Healthcare, so they're not just a payer, but they're also a provider. And does that lead itself well into a Medicare Advantage program as well?
Definitely. And the thing is, they would call themselves a local care delivery group. Again, we got so many acronyms, LCDOs, but the whole point of it is that they have the data. They have the claims data, and they're able to track and create a distillation of the different types of patients, their comorbidities, what's the risk factors, and then align them with the appropriate physicians. And they have the data in terms of evidence-based care. So for example, if a patient's getting IV therapy, do they need that IV therapy? Is there evidence-based to support it? And what about the patient able to afford the medications and then following up with the appropriate specialist? So they're able to track and create that touch points, as many as possible, to make sure that patient is not having problems with their comorbid conditions.
Okay, so we don't want to assume that everybody understands different things that have taken place. I came from Bank of America Merrill Lynch, and I think Bank of America bought Merrill Lynch in 2008. And I run into people today that go, is Merrill Lynch part of Bank of America? And so I don't want to assume that people understand that CVS bought Aetna. So that's a fairly new transaction, right?
Correct.
And how does that differ? That kind of fits into that play as well, doesn't it, for Medicare Advantage? Is there some pluses there? Kind of tell us a little bit about how that happened and how you see that going.
Right. And, the thing is, CVS is a PBM, so pharmaceutical benefit manager. And of course, they have a brick and mortar presence as well. And just for everybody, just a quick overview, a PBM or pharmacy business management is they will go ahead and procure those medications at a special rate based upon their discussion with drug manufacturers. And then they will then collaborate with payer groups as well as Medicare, Medicaid. So one of the things was they saw that, yes, they were a transactional company, but they wanted to be more of a transformative company. And the reason is they have the claims data now with Aetna, and they're able to then specifically go at those patients as well as collaborate with the providers to make sure that the goal is seeing their physicians, getting the appropriate level of care, and there is an efficiency in that matter.
So thinking about CVS, I know a few years ago, they made a very bold move. They eliminated tobacco products being sold. And I think that was really making a statement about we really care about health. We care about the people. And so what you're saying is combining the population health data and the analytics and all the things that Aetna has along with the transactional things really creates a transformative environment there. Okay, well, that's good to know. I've been to CVS, and I asked one of the people at the cash register the other day, I said, what does CVS stand for? And they thought maybe I was, a hidden manager or something like that. And they answered the question correctly. They said CVS stood for Customer Value Store. I didn't know that. Customer Value Store. And then I looked around and I see this Minute Clinic, and there's a lot of Minute Clinics there. Tell us about the history of that and how popular that is.
So Minute Clinic actually started out doing more for acute care. So your chronic cough, you got a bladder infection, or you have a rash. And, initially when Minute Clinic started, there was definitely a pushback in the medical community, and they were able to show through evidence base that the affordability, accessibility, and the quality of care was there. And one of the things that Minute Clinic is now doing is they're saying, look, we can treat the acute issues, but if we're going to bend the cost curve, if we're going to have more efficiency of healthcare, let's go ahead and let's take on chronic care management. And as you brought it up, what is the strategy with Aetna and CVS is now you have already a brick and mortar establishment. You already have a Minute Clinic. Why don't we go ahead and leverage that population health data? Let's go ahead and target those patients who have diabetes, hypertension. Let's get them to goal, but then also be a conduit so that if they are not seeing their PCP, they can still see Minute Clinic for chronic care management or create that connection back to their PCP and then educate the PCP what they have done. So it's more of working together rather than simply being a one-off opportunity for patients.
So the PCP we refer to as the primary care provider, right? And so a good idea, the CVS Minute Clinic, turns into a great idea, which is formulating called the CVS HealthHUB. And most people may not be aware of what's going on. But like you mentioned before, in Texas, a lot of things are piloted here. I know that down in Houston, there are 3 of these new CVS HealthHUBs. And I've been to one of them, and talk about transformative, not only in terms of strategy and philosophy, but in terms of the physical environment there. You go to the back right corner of the store, and it's got a nice floor. It's concierge environment. It has all types of intriguing things for people that are of the baby boomer age. It looks very, very comforting to them. A much better place than sitting in a primary care doctor. So tell us a little bit about the CVS Health Hub. What do you know about that?
So the idea about the CVS Health Hub is, again, we look at patients just simply as patients, but we have to change that paradigm and start looking at patients as consumers as well. And the idea is educate them, inform them, empower them. What are their benefits? What do those benefits entail? And it's great to just give them benefits, but then to also have a network. So you can have a patient who comes in for example, get a prescription. They go ahead and buy whatever stuff they buy at CVS, but now they can have a medication reconciliation, which basically means a pharmacist can go through all their meds, see any pitfalls there may be with multiple medications and their medical history, but then also educate them about preventative care options. And then, as I mentioned before, social determinants of health. There may be patients who are unable to see their provider. They're not able to afford meds. There may be a nutritional issue. So it gives them an opportunity to educate the patient. So the goal is you come into CVS, yes, you were going to buy your whatever groceries and pick up your medication, but now you're benefited from understanding all your benefits, but then also be able to get tapped back to the medical home. And that may be seeing your PCP or specialist, and then getting all the other ancillary benefits that can combat, which is one of the big things going on right now, is social determinants of health.
Yeah, I understand there's about 60 of these health hubs. And this year, in the year 2020, I've read the projected growth is to have 500. And by the end of next year, 2021, to actually have 1,500 of these health hubs in place. And those social determinants of health include things like cooking lessons and yoga, and a whole variety of things that really start to focus the individual on having a healthier life. And combined with Aetna, I heard also that there's a discount you get if you have your health plan with Aetna, that you get a discount on CVS products too. So that just kind of throws out this net of comfort to wrap in all of these baby boomers to say, look, we've got a better way to do things. So my question here is, how far can this primary care go? Is it unreasonable to think that you could extend a spine clinic into one of these health hubs and even offer more advanced services?
Yeah, and it goes back to the whole point is, if you think about the whole business strategy of CVS, right? It's a one-stop shop. It's a brick and mortar, but now they can leverage the population health data. They have the network of physicians as well as specialists. And one of the things they can do is, for example, you can have a patient who has chronic pain. The pharmacist can see the multiple medications. They can see the risk. They can see maybe is there concern for opiate dependency issues. But then also that particular patient may fall into a subset of patients where they can benefit from a high performance network. And what I mean by that means they can see a specialist who has demonstrated excellent quality care, or what we would call value-based care, which is the quality of care is there and the cost efficiency is also there as well. So you may have a patient who has chronic back pain. Do they need to go for back surgery? No. Do they need to have medication management? Definitely. Do they need to have possibility of physical therapy? That's a possibility as well, rather than simply getting a back surgery and then they fall into the rut of going back and forth to the ER or to the post-acute care network, and they never are getting better.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So if I was a primary care doctor, would I feel like this health hub environment is making a partner with me or disengaging me?
No, definitely it's going to be a partnership because, again, with Medicare Advantage, the goal is you have to have some reason or some framework to engage both the providers and the patients, or in this case, the consumers. So as I mentioned, there's an extrinsic, intrinsic motivation. You want to be able to have those providers who feel, look, I want to be able to track how well I'm doing. What's my impact to my patients? I only see them in my office only a fraction of their life. I want to know what's going on outside of that office space. And also, I want to get rewarded for my hard work. If I see a patient, get them in, see them as aggressive as possible, do late hours calling them using telephonic or telehealth to engage my patients, and I get them to goal, then what's the financial benefit as well?
Okay, let's shift gears just a little bit here. We've been talking about Medicare Advantage, and I think of that, obviously, the right solution for the boomers. And, most of the boomers, they want to age in place. Most of them aren't really financially prepared for this longevity bonus they're getting. They're going to live a lot longer. But the new customers, the millennials, they demand information. They're digital natives. They've been around the digital information. Not a lot of loyalty in place. They don't trust everybody. I'm characterizing here a little bit, but how do you address their needs? How does a CVS Aetna engage this new up and coming? Because the boomers are going to age out pretty soon here. So what's the strategy for that?
So I think it goes back. You're not looking at the millennial population as a patient population. You're looking at a consumer population. And then you're also looking at accessibility of care. So it may be utilizing wearables or digital devices that's able to, again, have as much touch points with that patient, or in this case, consumer, and be able to understand them and to be more readily accessible. That goes back to the strategy is that if you're using telehealth options to treat a patient population, it's great to go ahead and treat them, but then you want to be able to extend that to a brick and mortar. So for example, as you brought up, if you have an Aetna and a CVS strategy, and some of the Minute Clinics do use telehealth capacity, they may be able to, for example, I can cite Cleveland Clinic, they may be able to go ahead and say, I'm a millennial, I got treated for a cough and cold. By the way, I'm at a risk factor that I may need to have some preventative studies done. Well, you can have that warm handoff to a PCP, such as a Cleveland Clinic, and they're able to take it from there. Now, that's great because you've now saved a significant amount of time, energy, and frustration with that millennial group. And now they're able to get more engaged and more empowered in taking care of their health.
So we hear about disruptive innovation all the time, and some of these are the high-tech companies. So we hear about Google wanting to own all the health data in the world. Mm-hmm. We just had a discussion today with our physician group in class, and they're talking about how aggressive Google is getting about, managing data. And not only Google, but Apple as well. Apple wants to have a way to engage you in your health journey. And then Amazon, everybody talks about Amazon today. It's like, what aren't they getting into? If you're FedEx and you're shipping stuff, you go, Amazon might be my competition. Mm-hmm. They might buy more jets than we have and things of that nature. And I know that Amazon would love to be in the pharmacy business too. So how do you look at these high-tech companies? Do you see them as being cooperative, that you would work with them, or do they stand out as distinct competitors now?
No, I think it can be twofold. I think a lot of it is, there's something to be said about competition advantage versus efficiency in what you're doing. So you can also be able to utilize the technology. So for example, Amazon may be able to do a better job in data analytics. So you may be a healthcare entity and you may say, well, I'm not able to quote unquote crunch this data. You may utilize Amazon's technology to be able to pinpoint which is your patient population you want to target. Likewise, you may have someone like Optum who may say, okay, you know what? We have an issue with a particular business line of healthcare, and that might be pharmaceuticals. And they may be able to strategize or work with an Amazon or whichever other entity that comes into the marketplace. It's always great to have competition because if you think about it, in healthcare, we're the only type of business where you don't know how much it costs when you ask to get a type of service such as healthcare. And I think that's going to change with price transparency, knowing how much it costs. And you want to know what are your options. Unfortunately, right now, if you go see a doctor, and it goes back to the millennials, that might be a sore point is, I don't know how much it costs. I don't know how long it's going to take me, and I don't have a way to compare. Now you may have someone like an Amazon group or any other disruptive group that comes in. It's only going to raise the bar in terms of making it not only you're treating a patient, but you're treating them as a consumer. and you want to get the benefit for them to understand what are their options available, be able to get more engaged with their healthcare, and to have a better satisfaction rate. And that's some groups now even use what they call NPS scores, Net Promoter Scores, because it's not just getting your patients to goal with your diabetes, but are they happy with the whole process as well?
So I can see some futuristic things with Alexa. Alexa, what's my health savings account balance? Alexa, can you connect me with the Health Hub at CVS? Alexa, can you give me the records from my primary care doctor? All these different touch points to engage the millennials. And they want things delivered to them. They don't want to wait in line. They don't want to wait for things to happen for them. They don't want to talk to you, but when they do want to talk to you, they want to talk to you right now. So I can just see a big transformation taking place there, and thinking that that's a key element to really pay close attention to with these new technologies. So we'll shift gears again. These ACO, these accountable care organizations, they've been piloted for quite a while. They came out of CMS. Are they the real deal? Is this a temporary phase? You work with these organizations. Give us your perspective on that.
No, I think what it has done is, whether you call it an ACO or whatever iteration, or again, another acronym, you may call it, like there's Bundled Payment Care Initiative or BPCI or Advanced. I think the whole goal is it's trying to, again, as we were bringing up, trying to streamline, have the right appropriate data to be able to engage the correct patient population. Because you can imagine you have, let's say, for example, in Texas, you may have 1 million patients. You cannot call all 1 million patients, and they may not answer. So you can't use phone. Some of them may not be connected to a computer, and you don't know which of those patients you need to see today, next week, or next month. So the idea of the ACO model was really to get coordination of care. And it was really the infancy of what we talk about now, which is value-based care, which is quality divided by cost. So whether it's an ACO or a hybrid, or it's a value-based care, or whatever adjectives we want to use, I think the idea is, can we get a better care coordination, find out which are the patient population that are at high risk, and be able to target them, and not just target them by simply saying, come to the office. That's not going to work anymore. That's where the social determinant of health barriers come into play. That's where be able to meet them on their own terrain. And that may be using telehealth services, being used, using wearables, or as we were saying, having them at a CVS HealthHUB where you're able to engage them there as well.
That's a really interesting concept when you think about those social determinants of health, how important that is. I heard it stated once that the actual care, healthcare aspect of things may be 10%, but having access and quality and things of those nature that we typically don't have for everybody makes the big difference. I talk about I like to refer to the NRA. It's not the National Rifle Association, but it's having nutrition, rest, and activity. Those three things. How do you get people to understand those things, get the right nutrition, really understand how much important it is to have physical activity and the appropriate amount of rest? Those start to fit in very clearly in the education process, which I think is going to be a very key component of this new age technology as well.
Right. And one thing I would just want to add is, just to give an analogy, you may have a patient who may be literally 1 mile away from their PCP, but they're 5 miles away from their ER or a hospital. But there's a bus line that's easier for them to take to go to the ER. So you can see right there, there's a difference. And that's really impactful, because there are groups like Optum who believe that invest in transportation services. If that is the barrier, or quote unquote, the social determinants of health barrier is simply transportation, let's knock that down. Because you can imagine the cost of having someone in a van to transport them to go see their PCP is exponentially cheaper than having, over time, having them go to the ER, get admitted, and then get readmitted because they're not seeing the PCP.
That's that little prevention and pound of cure. It fits right in there. Hey, we're really glad to have Dr. Pardeep Shori on the Business of Healthcare podcast. Pardeep, it's a pleasure having you here. We're going to continue to follow you and stay in touch.
Awesome. Thank you so much.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.